Hello friends. I'll be talking on this physiology topic, transpulmonary pressure, just the physiology aspect of it, and how is it relevant from practical standpoint, and how do we apply this concept in our practical day-to-day ICU care. So this question has been asked for DNB as a short note. So it is important for all the trainees to have a bit of clarity on physiological understanding of this transpulmonary pressure and how is it useful from the practical standpoint. So maybe in just 8 to 10 minutes, I may be covering this. So I wish to thank my colleague Bhavya, who also helped in some of the content of this. So when you look at the lung, so when this question is asked in exams, so if I'm correcting a paper, one would expect that you explain this with the schematic diagrams. It makes life more easy. Otherwise, it's not really easy to explain the whole concept of transpulmonary pressure. So if you schematically look at the lung this way, and this is the pleura. So the gray area is the pleura. So transpulmonary pressure is basically a difference between the alveolar pressure and the pleural pressure. So the alveolar pressure, the way we measure it with the P-plat or plateau pressure. So you can call it as alveolar pressure or plateau pressure minus the intrapleural pressure. So the difference between this is what is called as transpulmonary pressure. So then the whole question is, we have maneuvers to measure P-plat. So we do end inspiratory hold and measure P-plat, which is a reflection of your alveolar pressure. But how do we measure intrapleural pressure? So intrapleural pressure is measured by this esophageal balloon. So that is where the whole value of this esophageal balloon catheter, which is placed in the esophagus, it takes a measurement of intrapleural pressure. And so the transpulmonary pressure is basically a difference between alveolar pressure and intrapleural pressure. And the one we measure is P-plat, which is the representative of alveolar pressure. So it's P-plat minus intrapleural pressure. And P-plat is usually positive. And as you know, in a spontaneously breathing patient, why transpulmonary pressure is important is because it is dependent on the pleural pressure, and the pleural pressure in a spontaneously breathing patient is a negative pressure. And another important thing for all our trainees to understand is the negative pleural pressure increases in a chest pathology. So if you have atelectasis, if you have a pneumonia, if you have ARDS, the negative pressure tends to increase when they're spontaneously breathing. I'll show you later on. So the intrapleural pressure is negative, plateau pressure is positive. Transpulmonary pressure can sort of fluctuate between little positive and negative. So that is our conceptual understanding. So this is just the waveforms in relation to the lung volume of transpulmonary pressure. And whenever we talk about transpulmonary pressure, so the pressure we talk in the setting of inspiration and we talk in the setting of expiration. So in the previous video, when I spoke about COPD, the whole problem lied with expiration. But when we talk about transpulmonary pressure, the whole problem rests with your inspiratory problem. See, because I said inspiration is an active process, expiration is passive process. So the whole pressure effect and the settings we do in pneumonia, ARDS, mainly the whole role of transpulmonary pressure comes into fore in a lung pathology if you're dealing with a patient with ARDS. So where your inspiratory efforts is what will cause all the changes and all the problems, and our understanding of inspiration is more important because expiration we do not have control, and that is where the problem during expiration is not much. It is mainly during the inspiration that we have more problems. So we need to understand as to how these pressures vary during inspiration. So again, another representative diagram. So when you look at it with a proper lung, so the P-plat is, as I said, is the alveolar pressure that you would see, which is measured as P-plat, and intrapleural pressure, and the difference is transpulmonary pressure is P-plat minus intrapleural pressure. Just another diagram in the lung. So the esophageal catheter will be sitting in the esophagus. So the difference between these two is what you measure as transpulmonary pressure. So another important caveat that we need to look at is, so what we call as intrapleural pressure, which is measured by the esophagus, ordinarily we take it as it is equivalent, but we need to bear in mind this. There is another component to this called the chest wall. The chest wall also has a bearing on the intrapleural pressure. So because the chest recoil characteristics get affected in ICU for various reasons, which I will tell. And this also has a bearing on the intrapleural pressure. So, but what your transpulmonary pressure does is it is partitioning, it is eliminating or it is taking as chest pressure, not having an effect. So it partitions between the chest wall issues, and it only takes your alveolar pressure and the intrapleural pressure. So the chest wall pressure is taken as not being affected. But in ICU, there are various conditions which affect the chest wall recoil or the chest wall mechanics. This also has a bearing on the intrapleural pressure. The intrapleural pressures can get worsened with lot of chest wall deformities, and that also has a bearing on increasing your transpulmonary pressure. So that is something you need to understand. So when we look at the lung apparatus, the transpulmonary pressure is a reflection of pleural pressure and the alveolar pressure. So lung and the pleura, but it does not take into account the chest wall pressure changes, because that also has a bearing on transpulmonary pressure. But when we measure, we mean we are only taking the lung and the intrapleural pressure. So again, this is to show that how your transpulmonary pressure changes with your lung volume. As you see, this is the transpulmonary pressure in a high volume, like emphysema patient. It has a higher volume, and this is in normal. And in low compliance, this is the waveform as to how your transpulmonary pressure looks. So especially transpulmonary pressure increases with your lower compliance, with the ARDS sort of a patient, and transpulmonary pressure will tend to be low in a emphysema or in normal patients. So in ventilated patients, in a volume targeted ventilation, you will see a waveform like this. So the red one is with a low compliance, where your transpulmonary pressure increases, or the green one is normal, and here is the emphysema patient where compliance is normal or increased, where transpulmonary pressures are less. So this is what we see in the pressure volume curve in the ventilator. So now we'll talk a little bit on the bearing of chest wall pressure. So I showed you a diagram. So when we ask about maybe transpulmonary pressure, any examiner, it is good that if you put it in a schematic diagram and tend to explain as to how the pressures are affected in different conditions. So I already said that esophageal manometer measures, it takes a surrogate of your pleural pressure. So there are conditions where esophageal pressures are high. So the increase in the esophageal pressure happens when there is reduced compliance of the chest wall. So the reduced compliance of the chest wall happens when there is pleural effusion, or when there is chest wall edema, or when there is a chest wall trauma. So any conditions which affects the chest wall, where you have sequestration of fluid in the muscles, where there is pleural effusion, or where there is chest wall trauma, or massive ascites, intra-abdominal hypertension, obesity, all these conditions lead to reduction in the chest wall compliance, which increases the esophageal pressure, which means your pleural pressures will go up, and then your transpulmonary pressure also tends to go up. So any condition where your lung compliance is down, like in ARDS, your transpulmonary pressure goes up. If your chest wall is affected because of pleural effusion, obesity, intra-abdominal hypertension, ascites, chest wall, all this can increase transpulmonary pressure, because chest wall also has a bearing on your pleural pressure. So that is something you need to understand conceptually. So as I said, the esophageal pressure has a bearing, it correlates with the intrapleural pressure, and this can get affected when there is mediastinal artifact or any of these conditions are present. Your esophageal pressure can go up, and your transpulmonary pressure obviously will be higher. So, and transpulmonary pressure can be used for the setting of the PEEP also. So it is suggested or desirable that we keep during end expiration transpulmonary pressure at 0 to 10. But as I said, the whole problem of transpulmonary pressure happens mainly in the inspiration problem, because as I said, the whole concept of transpulmonary pressure, we have to focus on inspiration, how it has an impact. During expiration, it is not a problem, because the PEEP, as you said, transpulmonary pressure will be less. But during inspiration, transpulmonary pressure goes up because of your inspiratory pressure. So we have to keep it less than 25 centimeters at the end of inspiration. And you can look at transpulmonary as P-plat, where we say P-plat has to be less than 30, should be little less than that is what your target should be. So now the whole question is, we have understood physiologically the correlation as to how your pleural pressure and your alveolar pressure has a bearing on transpulmonary pressure. But how do we apply this in our clinical practice in patients with compliance issues like ARDS? So that, I think I put it in a very figuratively, in a schematic way for you to have an understanding how this concept of transpulmonary pressure can be applied from the practical sense. Okay, so I'll just go slowly here. So here you have, as I said, the problem of transpulmonary is during inspiration. Look only during inspiration. So during expiration, so what happens? You have a you consider this as a lung with a pneumonia or atelectasis. So you have a diseased alveoli here, where alveoli is collapsed. To open this, what do? You apply a PEEP of +5. So during expiration, there is no role of inspiratory pressure, right? So there's no, you don't put inspiratory pressure. What what is needed in expiration is the PEEP. So here you put a PEEP of 5. So your alveolar pressure is 5. Airway pressure or alveolar pressure is 5. So your transpulmonary pressure during expiration is, which I said, what is transpulmonary pressure? It is P flat or alveolar pressure minus pleural pressure, which is alveolar pressure is 5 minus pleural pressure, it becomes 6. And I said, wherever there is a disease, your pleural pressure will be high, because wherever there is disease, there will be more negative pressure generated in a in an area where there is pathology in a spontaneous breathing. So what is transpulmonary pressure here? So it is 5 minus of -2, which is 7. So there is this is this is no problem. But I have already said your whole concept of transpulmonary pressure and the problems of it is with inspiration. So in inspiration, you are putting inspiratory pressure. So there is a PEEP of 5. Then there is an inspiratory pressure, which is pressure support you put of 8 in ventilator. So in a normal lung, this 8 is adding on to 5. 5 plus 8 is 13. So what is happening here? Normal lung, you are causing over distension. Dependent lung, so your transpulmonary pressure is 15, which is 13 minus of -2. Here, what is happening? Your negative pleural pressure is more because it is a diseased lung during inspiration. So transpulmonary pressure becomes 18. So you have not done anything to the diseased alveoli, but by putting pressure support of 8, what we have done is we have over distended the normal alveoli during inspiration. What is that? It manifests in our ICU with this problem is it is volute trauma. Volute trauma is because of the shearing forces, closing and opening of the normal alveoli in the presence of the pathology. There is a over distension, which we call as volute trauma. This is how we apply this concept of transpulmonary pressure, why it is important. So we don't want any of this. Both are bad because you have a diseased lung and you have put in the parameters which has really not opened up the or recruited the collapsed alveoli, right? You have not opened up the collapsed alveoli, but in return you have over distended your normal alveoli causing volute trauma. Okay, we don't want this. We'll go to the next scenario. So now a clever registrar comes, he's added a PEEP of 10. So that's good. So expiration, it's not a problem. So expiration, you've given 10 of PEEP, pleural pressure. So transpulmonary pressure is 11, pulmonary pressure is 12. But during inspiration, you are hoping it will open up. So yes, you put a PEEP of 10 and you put pressure support of 8. So 10 plus 8 is 18. So your transpulmonary pressure is become 20 on non-dependent. Dependent, because you've added pressure support, so transpulmonary pressure is become 23. So the sort of alveoli is sort of opened up because you've increased the PEEP here. But is this okay? So this 23, because it causes atelectode trauma, which means it has opened, but it is the pressures are or something which is not safe, and this causes something called atelectode trauma. And this is also something which we don't want because we want PEEP to open up. Here is because in see why I say atelectode trauma, in expiration it's not open. But in inspiration, it has opened, which means there is a shearing force. There is an opening and closing. This shearing force with an inappropriate PEEP is what is called in atelectode trauma. Even this is not something which is desirable. So the registrar also has done a right thing by increasing the PEEP, but by putting pressure support and PEEP not being optimal, he still kept it collapsed in expiration, but in inspiration, it is opened up. So opening and closing is causing atelectode trauma. Before you saw normal one getting over distended, it was volute trauma. Okay. Now a third registrar comes. So he's a very clever guy. He puts 14 PEEP. So during expiration, 14 PEEP has opened up this collapsed alveoli, and I see transpulmonary pressure is 16, 18. So he's done a good thing. He's increased the PEEP, opened up the recruitable alveoli. Let us use the word recruitable rather than collapsed alveoli. Recruitable alveoli. But then what he does, the clever registrar again has put pressure support of 8. So what happens? Your transpulmonary pressure is 26 on inspiration. On the recruitable lung, it became 30. So is this desirable? So you see all the four alveoli are open. During inspiration, it's open, during expiration. But here there is little bit of a high transpulmonary because plateau pressure has to be less than 30. It's gone up to 30 here. So he has recruited well, but with possible overdistension. This can cause barotrauma. So has your registrar done the right thing? He has done right thing in expiration, but he or she has not done the right thing during inspiration. Inspiration, he can cause barotrauma and emphysema that can happen. So this is also right thing. So after that, maybe a consultant will come and then he does this. He puts a PEEP, which is fantastic. He opens up both alveoli, he or she opens up both alveoli during expiration. And during inspiration, what is the clever consultant does? He reduces the pressure support. He puts the PEEP at 14, but keeps a very less pressure support. So what that has done, so it has kept the plateau pressure less than 30, 22, and and in the non-dependent 19. So this is a state compatible with lung protection. This is the whole concept as to how we apply the concept of transpulmonary pressure. Why it is important? Because your inspiratory, I said the whole understanding of transpulmonary pressure is with inspiration. It is an inspiratory pressure that you have to keep an eye. If you keep very high inspiratory pressures, it will lead to uh, deleterious changes or detrimental changes by increasing your transpulmonary pressure, which is the difference between the alveolar pressure or P flat and the intrapleural pressure. Bear in mind, this we are talking about only lung pathology. At the same time, concurrently, you need to look at chest wall also, which also has a bearing on increasing the transpulmonary pressure because the pleural pressure is influenced by both the pathology in the lung and with the chest wall also. So this is the concept. So I request every trainee, if this question was asked in DNB, if it is asked, please put these figures because if you don't put these schematic diagrams, it's very hard to explain how this whole transpulmonary pressure. So one figure with a lung, pleura, and a chest wall is not difficult to draw and put the pressures. Examiner will instantly know that you have conceptually understood this very well. And it gives a lot of confidence into all of us in having good clarity on this understanding. So hope this is made clear. So you can visit my website www.drpradipranka.com to rehear to this lecture. So thank you, one and all. So this is the right sort of a measures. So thank you all. Yeah. Hello friends. So I'll be talking on this concept of mechanical power. So I'm sure most of you would have been hearing about this mechanical power as a relatively newer concept, and I'm sure you may have heard in few of the conferences. So I still feel there is a lot of non-clarity in understanding this concept of mechanical power. So I'll try to simplify and try to look at it from a practical standpoint as to how relevant is this in dealing with the ARDS patients who are on mechanical ventilator. So wish to acknowledge my colleague, Dr. Pradeep, who also helped me develop this content. So I would use the symbol throughout the presentation so as a symbol of mechanical power. So the topics that I would cover is just a bit of background as to why we believe this mechanical power is become important and we need to have some clarity on this. So just take you very briefly through the timelines of various concepts that have evolved in the ARDS, be it low tidal volume, be it plateau pressure, be it driving pressure, so on and so forth, and why this concept of mechanical power. And then the question that we need to ask is the P plat, which we were so much adhering to as a quality benchmark, less than 30 or less than 28 in ARDS. Has this been good enough in managing ARDS? I'm sure all the listeners know that we derived at P plat. Then after this, the thing that got emerged from P plat was the driving pressure. So now we are talking about mechanical power. So is there a need for this mechanical power? And when we talk about mechanical power, what is the number that we need to have in mind? What number of mechanical power is something that we all can be comfortable with? And very briefly on the what is the current evidence? So because most important, I've heard talks on mechanical power where we have conceptually tried to understand various nuances as to how we derive the mechanical power. But it is important to see whether this is relevant from the practical standpoint and whether there has been clinical application of this. And then we look into most important is to understand, are there any new strategies to optimize mechanical? I think this is also very important because all of us understand conceptually mechanical power, but what are the strategies that we have to optimize mechanical power? And to that effect, as an extension, I would talk a bit on adaptive support, and I'll tell you why we have to talk on that. And is ECMO a solution if we fail with all our maneuvers in trying to minimize our mechanical power, and summary? So these are the topics that I will take you through. So we have clearly understood that in patients with ARDS, most harm is caused by ventilator-induced lung injury. As you see, this alveoli is over-distended and there is lung injury that happens. And we have clearly understood over many years that it is the tidal volume, low tidal volume, P-flat less than 28, driving pressure less than 50 are found to be protective and help in mitigating the ventilator-induced lung injury. And it is shown if these are not well maintained, there is significant mortality correlation if we are not looking at these variables from the close quarters. So when we talk about mechanical of power, in addition to these three elements of low tidal volume, plateau pressure, and driving pressure, we are looking at other aspects. We are looking at the overall pressure, overall volume of the respiratory system, the flow dynamics, and most importantly, for all the listeners, you can bear in mind the respiratory rate, which was not added in any of the previous sort of a variables that would have an influence, has given due emphasis in mechanical. So they take this respiratory rate, they take flow. So they pretty much take all the elements that mechanical ventilator deals with, along with low tidal volume, P flat, and driving pressure, and see whether this has an ability to mitigate or reduce the ventilator-induced lung injury. And we know there are a lot of lung injuries that happen in ARDS. So Willi is we have understood. Then we know there is atelectotrauma. Then there is barotrauma that happens due to high pressures. Then there is something called biotrauma, which happens due to a lot of inflammatory process that happens in the lung due to the leakage of alveolar exudates, inflammation, and so on and so forth. And then the recently you might have been hearing there is a whole thing about PCL. So these are the different types of injuries that lungs would be threatened with in ARDS when they are mechanically ventilated. So this I'm sure you're all aware, and we need to be aware of these sort of injuries. So let us look into the timelines on the evolution of protective strategies in ARDS. So in 1974, the whole concept of high inspiratory pressure came in, and then there was a concept that P flat should be maintained less than 30 centimeter of water. In 1985, the whole debate was, initially our whole thought was barotrauma causes more harm to the lungs. In 1985, the concept of volutrauma came. That is where the emphasis shifted from barotrauma to more of volume causing injury, and we have discussed on this. In 1986, the concept of baby lung concept came, and PEEP application as a concept came in around 1986. In 1988, there was a new nomenclature that was introduced called atelectotrauma due to the uh, repetitive closure and opening up of the alveoli in atelectasis leading to trauma. Then 1990 came the concept of permissive hypercapnia as an acceptable strategy in ARDS. But there was no clear sort of a indication as to how much CO2 is safe. I think that is where we are coming down to. The too much CO2 also may not be good. So initially we accepted if CO2 is high, as long as pH is okay, we are still okay. But so that those concepts are slowly changing. 1992, we came out with the concept of open lung ventilation, where we incorporated low tidal volume with a high peak to have an adequate recruitability of the lung and ventilation of the lung. 1997, the concept of biotrauma came, where the inherent damage to the lung due to the whole inflammatory process, exudates, and the inflammatory mediators causing disruption of the alveolar architecture is called as biotrauma. And at around 1997 to 2000, the whole concept and understanding of maintaining tidal volume less than 8 ml per kg of rated body weight and the PEEP table came from the ARDSNet group. And all these were adopted as tools to manage ARDS in a safe way. So these were some of the timelines. 2008, so until 2000 to 2008, things remained pretty much adhering to low tidal volume, PEEP table, optimizing PEEP, open lung. Then the whole concept of transpulmonary pressure came. People started introducing the esophageal probes to measure the pleural pressures. because transpulmonary pressure is the difference between airway pressure minus pleural pressure, and esophageal pressure was taken as a surrogate of pleural pressure. So, and esophageal pressure was, so this was used as a means to titrate the PEEP. So transpulmonary pressure as a concept came in 2008. And 2013, there was a talk on stress and strain index. And 2015, so this is very important step. So from 2000, where we knew low tidal volume, we knew PEEP plat, we knew PEEP optimization, but then the new terminology came in 2015, which was the driving pressure, which is, I'm sure all the listeners here know that we now focus more on driving pressure because it takes PEEP plat and PEEP optimization together and looks at maintaining the driving pressure less than 50 as an important correlative effect on the outcomes and mortality. So the driving pressures and PEEP optimization based on the driving pressure as a concept emerged in 2015. So mechanical power is an extension of our driving pressure. It takes more variables. So basically what you are seeing is we have clearly understood there is not one variable which influences the outcome in ARDS. Initially, we thought low tidal volume, then we added PEEP, then we added plateau pressure. So now we have added driving pressure. So now we are adding more variables. So basically, all the variables that ventilator offers to the patient are taken into consideration and come out with this mechanical power. So in a simplistic way, you all can bear in mind that it involves all these components in addition to respiratory rate, which was not factored in most of these other previous dimensions. So if you remember that, I think conceptually, you will know it's just an extension of all these newer modalities. 2018, we came with a closed loop ventilation where ventilator itself auto adjusts pressure, volume, flow rates to the patient's needs. So this is a new concept that evolved in 2000, and all the newer ventilators which all my listeners would be having in their units, they would have a closed loop ventilation. So like you have adaptive support ventilation, you have proportional assist ventilation. So you have pressure guaranteed volume control ventilation, so on and so forth. So there's a separate video on that. You can go watch it. And 2019, already this is in market. So I think I've been making this statement in the days to come. We don't need possibly to have ventilatory workshops because everything is AI generated. So ventilators will auto sense the need for the patient and it will titrate the flow rates, volume, pressures, and auto adjust. So this is already in the market. So Neo Ganesh, which draggers have. And so there are these algorithms which are incorporated in the newer ventilators. So the AI modeled ventilators are already in the market. So Neo Ganesh is one of them. There is a better care software which is incorporated in the new age ventilator, which is a AI generated. So 2019, we are moving towards AI sort of a influenced ventilators. 2022, currently the norms that we adhere to as a safe ventilation is tidal volume less than or 4 to 8 ml per predicted body weight, P plat less than 28, and PEEP. There is no ideal PEEP. PEEP has to be individualized based on the driving pressure. That is the norm we have agreed upon. And the driving pressure less than 13 centimeter is what. So we are going less and less. So these are the norms that we subscribe to even at this point of time. So this is the timelines as to how the ventilatory concepts have evolved over last 20 to 30 years. So just looking at all these awful injuries, 1973, as I initially elucidated to, the barotrauma was given more emphasis, saying the pressures are more harmful. Then 1986, the move was that it is volume which is causing more problems. So volume trauma was emphasized in 1986. 1997, atelectotrauma got emphasized. 2016, we are talking about ergo trauma. So why mechanical power? Because this is a new nomenclature which got introduced in 2016 saying ergo trauma, and this ergo trauma is influenced by various forces, and that's where the importance of understanding the mechanical power came into concept. So what is ergo? So when you talk about mechanical power, so if you have to simplistically look at the variables that influence, as you see, there is respiratory rate, there is tidal volume, there is resistance, there is flow, there is compliance, volume, and P. So these are the factors that influence the mechanical power of the lung. And each of these factor is attributed to certain types of injury. So respiratory rate causes injury to the lungs, which is called chrono injury. So that is due to the energy transfer that happens to the lung. And tidal volume, you all know it is volutrauma. Then there is resistance and flow. It causes something called rheotrauma. And energy trauma is due to the volume divided by compliance. And PEEP is at electrotrauma. So the combination, the cumulative effect of all this trauma is called ergotrauma because each and every variable. So simplistically to understand, each and every variable we set on the ventilator has an influence on causing injury to the lung. That's why we need to understand all this leads to cumulatively, which we call as mechanical power. So then the question comes, P flat of 30, is this enough? So we have understood the transpulmonary pressure, which is a airway pressure minus pleural pressure, may not be the only indicator that can determine how safe are we ventilating the patients. So mechanical power is the energy that a ventilator transfers to the patient who is ventilated, causing injury to the lungs. So all the settings you do, respiratory rate, flow, volume, PEEP, driving pressure, P flat, all this when we set all these, there is a transfer of energy to the patients who's on a ventilator, which is calculated as joules per minute, and that is what we call as mechanical power. So, for all my brilliant listeners, if you want to remember, this is a simplistic formula: power, which is joules per minute. So if you don't remember that, the formulas which these are further split into three categories because when we talk about mechanical power, so there is elastic component and there is resistive component. For me, it is easier to remember this formula. In elastic component, there is a static and dynamic. So the static power or elastic component is 0.098 into tidal volume into respiratory rate into PEEP. Easy to remember. So you just have to remember these three things: 0.098 into tidal volume into, and the last one you keep changing. For dynamic, it is same thing: 0.098 into tidal volume into respiratory rate into half of driving pressure. And for resistive, because resistance of the airways is dependent on the peak pressure, so it is just 0.098 into tidal volume into respiratory rate into peak pressures minus flat. So very easy to remember. So I'm sure for all the listeners, this is the easiest way of remembering three sub-variants of mechanical power, which is a static elastic power component, dynamic elastic component of the power, and resistive component to the power. So this is the simplistic way we can remember. And even there are studies to see which has the greatest influence on the mechanical power. And the greatest influence on mechanical power is the dynamic elastic component, which has a greatest influence on the mechanical power. And I'll show you some of the studies. So now the question remains after using this formula. So this is the total formula for the mechanical power. So you will get it as joules per minute. And what number of mechanical power? The studies have shown 17 joules per minute or less is considered safe for the lungs. Anything more than 17 joules per minute is shown to be harmful. So as I said, mechanical cover, if it is more than 17 joules per minute using those formulas, it is shown to have correlation with increasing in the mortality. So where did this number come from? So there are studies done. So this study was by Dutch group. It's called Proof Network Investigators. So basically all these studies which I'll talk about mechanical power, they took all the ARDS patients from all the major trials, like Accuracy's trial, ArtsNet trial. So all the database patients they took, and they did a computational modeling with various pressures and saw which sort of a pressure had a major effect on the mechanical power. So the Sarpa Neto et al., which is a Proof Network Investigators, which was published in Intensive Care Medicine, took two observational studies of mechanical power, and they showed mechanical power had a good correlation with ICU and hospital mortality, ICU and hospital length of stay, and ventilatory-free days, even when low tidal volumes were maintained. So, which means to say, emphasizing that just saying I'll maintain my patients on low tidal volume, optimal PEEP, driving pressure less than 50 at this point of time may not be good enough. One needs to look at an additional component called mechanical power, which factors in respiratory rate, also along with other things you saw in the formula. So Cresoni et al. From Italy at low tidal volume. So they looked at and with a high respiratory rate where there was a mechanical power of more than 12 joules per minute in peaks caused VILI, ventilator induced lung injury, even at low tidal volume. And they showed in this particular study when there is a shortened inspiratory time where IE ratio is maintained by if you shorten inspiratory time, there is increase in the inspiratory flow that you have to do. That increases the airway pressure and that increases the mechanical power. So basically, don't have to memorize all this. What it says is tweaking of one variable has a bearing on other variables and it increases the mechanical power. Like here, you are saying respiratory rate increase the risk of mechanical power. And here, by shortening the inspiratory time, we know you have to increase the inspiratory flow, airway pressure goes up, and mechanical power increases. This was shown in animal models as a precedent. So, what about human studies? So, this was a study that came from the French group in intensive care medicine, Gurin et al. They looked at 787 patients with ARDS, and these patients were not recruited. These were the database patients taken from Accuracy trial and Proseva trial, and they showed that mechanical power had a good correlation with survival. With every 1 unit increase in the mechanical power, there was an increase of hazard ratio of 1.03 on the survival, which means 1 unit increase in mechanical power has a bearing on increasing in the mortality. This was shown in this particular study. This is a big study which I did mention, which came from the PRU network investigation, Sarpa Neta et al. 2018. This is the largest study, 8,207 patients from the big database called the MIMIC database and the EICU database, where they showed these patients were on low tidal volume and low driving pressure. They had low driving pressure, they had low tidal volume, but what they showed is if mechanical power was high, even in these patients, where so now we cannot take comfort saying I'm maintaining low tidal volume, low driving pressure. But if mechanical power is high, it had increase in the mortality, and that was statistically significant. Odds ratio was 1.7, and if you see the confidence interval, it was significant. So these studies are re-emphasizing that we need to pay attention to this concept called mechanical power. So gone are the days where we can say, okay, P plat is less than 28 and your driving pressure is less than 15 and I'm optimized PEEP, so patient will do well. So we have to look at this component of mechanical power was what came out of these studies. And Zhang et al., they looked at 5,159 patients from 8 randomized control trials. Here he gave emphasis on looking at mechanical power per body weight. So I said mechanical power of 17 joules per minute or less should be there. In Zhang et al., they looked at per kg. Per kg, you can keep a figure of 0.32 joules per minute per kg. So that is the sort of figure they are at, 0.32 joules per kg. So they said predicted body weight based mechanical power versus absolute was found to be superior and they found it significant. These are all computational models. Don't get too much mind into how they did studies. They only took the data, they did the mathematical modeling, like which variable had a major impact on the power. That's all it is. So don't complicate things. So this is the most recent study. Again, it is a computational modeling they did on the large database. So this came in 2021. This is the latest study which came from the Brazilian group. As you see the title, ventilatory variables and mechanical power in patients with ARDS. Here they took 4,549 patients, again from the database. Here the average mechanical power per kg. This is like Zhang et al. Said, look at mechanical power per kg. So for all the listeners, keep 17 joules as an indicator. If it is per kg, predicted body weight, it's 0.32 plus or minus 0.14 joules per minute was the average mechanical power. And the driving pressure in this database was 15 plus or minus 5.8, and respiratory rate was 25.7 plus or minus 7.4 beats per minute. And what they showed in this study was the driving pressure had, so these were the predictors of mortality, and the driving pressure's effect was 4 times that of respiratory rate. So this is a very important message that came, which tells the driving pressure has much more profound effect than the respiratory rate. So the effect is 4 times impactful is to that of respiratory rate, which means the driving pressure is 4 times more effective than the respiratory rate. So although we are paying attention to the respiratory rate in mechanical power, still the driving pressure has more value because its impact was more on, and its impact on influencing the outcomes was more with driving pressure. It was 4 times better than respiratory rate. But having said that, respiratory rate also has a bearing on mechanical power. And if you look at the forest plot, this is a very important. If you see the driving pressure, the odds ratio was 1.31, statistically significant. But if you look at power, the odds ratio was 1 point. So what it is telling you, driving pressure is still a very good marker because the odds ratio is better than the mechanical power. And here I told you in mechanical power, there is an elastic component of the mechanical power. And here, as you see, they have looked at elastic dynamic and elastic static, and elastic dynamic had a maximum impact on the mortality, which was 1.31. And as you say, then they came out with this formula 4 times. This formula came from the findings of the study that delta P or the driving pressure at 4 times the effect of respiratory rate. So they combined both. So they took 4 times the driving pressure plus respiratory rate had a maximum impact on mortality. That's what came out of this study. Very good study. So basically from this study, very summarily, what we can deduce is that 4 into 4 into driving pressure plus PEEP, these two variables as a component had a major impact on the mortality, and that came out from this study. And if we have to look at the power, it was the elastic dynamic component which had the second maximum effect, followed by the mechanical power. So this is what came out from this. Just to remind you again of the elastic dynamic, this is a simplistic formula. 0.098 into tidal volume into respiratory rate into half of driving pressure. So driving pressure is coming in everything. So which means again driving pressure appears to be most important, and add it with respiratory rate. So 4 times the driving pressure is what has a maximum impact on the power, mechanical power. So now we'll move very slowly to how do we optimize mechanical power? If mechanical power is high, use this formula. And because we had, as I'm giving this talk, I have a patient on ARDS who is prone position. We did a mechanical power, it was 24. Obviously, we have to incorporate strategies because this patient right now who is prone has a driving pressure of around 14 this morning and has a P plat of around 28, 26, but mechanical power is 24. So we are obviously putting in, we need to understand the strategies as to how we reduce the mechanical power. So how do we optimize power? So there are two broad categories. The first category is obviously we have to reduce the production of CO2. So this is where it is important because we said permissive hypercapnia was a friendly concept we were comfortable with, but no longer can we be comfortable because if carbon dioxide is going high, mechanical power keeps increasing. And second component is enhancing ventilatory efficiency. How do we reduce carbon dioxide? It's all the archaic intuitive sort of a practices that we have been doing. So we have to optimize sedation, optimize analgesia, paralyze the patient we have in question in our ICU right now. We have obviously she's on paralysis, and temperature control, reduce the sympathetic activity, so on and so forth. And how do we enhance mechanical ventilation? There is a one strategy that they've come out with this. So giving an end inspiratory pause, if that is prolonged, it has some ability in reducing dead space, prone position, which we do, and PEEP optimizations. All these are something which we have been doing, but end inspiratory pause, which can be prolonged for some time, has shown to have some effect on reducing dead space. But for us, the easiest one, the another important aspect that came out in optimizing power was adaptive support ventilation. So I think that is something which we should. So adaptive support ventilation is shown to have favorable effect on reducing the mechanical power. Is there clinical study? I'll take you through that. So what is adaptive support? So adaptive support ventilation. So I use G ventilators and Drager, but my ventilators do not at this point of time have adaptive support ventilation. Hamilton and Drager Evita have. So adaptive support is where breathing optimization happens commensurating to the respiratory system mechanics. So when there is low compliance, typically in ARDS, there is low compliance. So the compensatory mechanism to to reduce the work of breathing is rapid shallow breathing. So they do rapid shallow breathing in the low compliance. And in patients with high resistance, so your work of breathing can be reduced by slow deep breathing because you need a prolonged expiratory phase. So what adaptive support ventilation does is you fix a minute ventilation, and the ventilator plots a graph to titrate tidal volume to achieve the target flow rate that you have set at an optimal level. So basically it plots the graph to optimize the tidal volume to achieve the set minute ventilation at a set flow rate. So this is happening to the patient's needs. So the parameters that we set in adaptive support ventilation is you have to put body weight and what is the minute ventilation we are intending to achieve, what is the PEEP that we need and trigger, and ventilator automatically measures the compliance and resistance. And here, the most important is that end inspiratory pause I said, ventilator is doing. It optimizes inspiratory and expiratory ratio, avoids auto PEEP, and it sets the tidal volume and respiratory rate by plotting the graph to achieve the set minute ventilation. So ventilator is doing pretty much everything for you based on the patient's needs by plotting the graph. So is there a clinical evidence? Yes, there was a study that came from Germany. So this was the Bichers et al., where they had adaptive support ventilation group and control group in ARDS. And as you see, the CO2s were similar. But when they looked at mechanical power, it was significantly less in adaptive support ventilation. It was 16 joules as opposed to 18.6 joules in the conventional group. So that is where they said that adaptive support ventilation may have some beneficial effect in reducing the mechanical power in addition to all the other tools that we incorporate like PEEP optimization, sedation, analgesia, reducing the dead space, so on and so forth. So if all this fails, you have done adequate analgesia, adequate sedation, you have done adequate PEEP optimization, reduce the dead space, done prone ventilation, all this fails, then what is the solution? Solution is ECMO. So this is adaptive support ventilation on the Hamilton ventilator. So it, as you see, there is a graph that is plotted to attain the set tidal volume at a set flow rate to attain the minute ventilation. So if all this has failed, then ECMO. So what I'm increasingly understanding is, so with all these parameters, if you are failing, then there is a clear indicator that we need to look at alternate strategy, which is ECMO. Because if CO2s are, so if you have to incorporate our EOLIAS criteria, where CO2 more than 60 and pH less than 7.29 for 6 hours, you have to consider ECMO. So, and this is emphasized. If we cannot, gone are the days we can tolerate higher CO2s now, where permissive hypercapnia, even 80, we cannot accept now. It has to be less than 60 because it increases mechanical power. So has there been any studies looking at ECMO and its effect on mechanical power? Yes, there are studies. So if there is increasing mechanical power, despite all these strategies, then obviously you have to consider ECMO. So there is this study where they have shown that in two groups where they took patients with higher mechanical power, like our patient right now is on 23, which we are contemplating on putting on ECMO. So if higher mechanical power patients invariably went to ECMO, and patients with lower mechanical ventilator did not need ECMO. It was shown in one of the retrospective study. And post ECMO, because you are resting the lung, you can see the mechanical power significantly comes down to 6.6 joules per minute as compared to no ECMO, 26.1. So which means to say ECMO rests the lungs and mechanical power will significantly come down. So that's about mechanical power. So the summary is, so we have moved a long way since 1974 when I was born to 2013, 2023, where we have come with tidal volume, P-flat, and driving pressure. Now we are talking about including mechanical power, where we are adding all the sort of variables. We are putting them into a mixer along with respiratory rate, which was underemphasized in all these previous sort of a novel approaches, and showing how this mechanical power has an influence on ventilator-induced lung injury, and this has a direct bearing on mortality, which we have seen in the clinical studies. So the power calculation for all my training, simplistically, you can remember there are three components. So there is a elastic static component and elastic dynamic component, and there is a resistive component. You have to only remember three variables in this: 0.098 into tidal volume into respiratory rate. The last variable you have to change into P into half of the driving pressure into P peak minus P flat. So if you remember this much as a conceptual understanding, it's not only a conceptual understanding, it has a practical bearing. So from now on, we have to look at mechanical power in all our ARDS patients. And if mechanical power is, you are maintaining more than 17 and you're not able to bring it down, and that may be a clear indicator, despite patient having driving pressure less than 15, despite having P flat less than 28, possibly their outcomes may be bad, and you may have to consider alternative strategies like adaptive support ventilation or maybe ECMO. So the threshold for patients going on ECMO are slowly coming down. I think increasingly possibly we are entering an era we may be embracing more of ECMO as a strategy because of the signals that are coming out from these sort of studies indicating how important is mechanical work. So thank you very much. And summary, there is a good evidence, and these are the very flow chart of how we optimize and so on and so forth. So thank you one and all. So I request you all to submit your valuable work to a journal which comes out every 3 months. So you can visit my website www.drpradeepangappa.com to rehear to this lecture. Thank you. Thank you one and all.